The following case presentation will be narrated by Laura Holman and Stephanie Davenport.
Adam is a 56-year-old Caucasian male who was brought to the emergency room by his wife after complaining of chest pain, indigestion, and heartburn that had been going on for several hours. He was admitted to the coronary care unit with a diagnosis of myocardial infarction and coronary artery disease. Adam is 5 feet 8 inches tall and weighs 200 pounds. Adam's myocardial infarction is one of moderate nature with damage to the heart evident on an EKG. A myocardial infarction, or MI, is defined as death of the heart muscle caused by lack of blood flow caused by an obstruction of a coronary artery by thrombosed plaque or spasm. This means that part of the heart muscle has died as a result of the lack of oxygen. Coronary artery disease is the most common type of heart disease and is the leading cause of death in both men and women.
Adam has secondary diagnoses of gastric ulcers and tendinitis of the elbow, neither of which were reported to be interfering with his ADLs prior to the MI. Though Adam has no documented history of heart disease, his father died from a heart attack at the age of 62. Prior to admission, Adam was independent in all of his daily life functions. Adam has no known allergies and is currently taking multiple medications for his heart condition, such as aspirin, beta blockers, and nitrates.
Adam is married with 2 sons, one who is away at college and one who lives at home. Adam works around 70 hours per week as an executive at a successful technology firm. His job is very important to him, and he wakes up early and comes home late due to the time he spends at the office. He is a heavy coffee drinker and smokes about 2 packs of cigarettes a day. Adam lives in a large 2-story home, and all of the bedrooms and full baths are upstairs. Additionally, he has to walk up 5 steps to enter his house from the garage. Adam enjoys golfing and sailing and taking his family on vacations twice a year.
Adam was referred to occupational therapy to address his decreased endurance, his dependence in activities of daily living, and instrumental activities of daily living and transfers. Some typical goals of inpatient cardiac rehabilitation include to prevent muscle loss from bed rest, assess patient's ability to function, educate patient regarding risk factors, self-care, and energy conservation education.
Adam was evaluated 1 week after his MI on the coronary care floor. Major areas that were assessed included his activities of daily living, his range of motion, functional strength and endurance, coordination, transferability, his desired roles, as well as his cognition, sensation, perception, and vision. Some assessments used to evaluate these areas included the COPM, the FIM, range of motion using a goniometer, the Borg rate of perceived exertion scale, various cognitive, sensory perceptual, and visual screenings, as well as an informal observation of strength during functional activities. The COPM, or Canadian Occupational Performance Measure, is a semi-structured interview that was administered to gather information regarding Adam's perception of his occupational performance. Through this outcome measure, Adam identified occupational performance problems in the areas of activities of daily living, instrumental activities of daily living, work, and active recreation. Adam's personal goal of wanting to return home and to work as soon as possible was identified during this interview.
The FIM, or Functional Independence Measure, is a performance-based observation that measures and assesses the level of disability in 18 items on a 7-point scale over a period of time to determine functional changes. This standardized assessment was used by Adam's OT to measure his level of independence in self-care and transfers. Currently, Adam is dependent for his ADLs and IADLs. Adam can transfer from the bed to the chair and from sit to stand with supervision. While in supine to sit, Adam requires minimum assistance and his bed mobility is independent using bed rails. The Borg rate of perceived exertion scale was used to assess Adam's perception of exertion during work, which is typically felt as strain and fatigue in the muscles and as breathlessness or aches in the chest. Adam identified his ADLs being a 17, which means that they are very hard and strenuous work, but one can still go on, but has to push his or herself and is very tired while doing so. On transfers, Adam identified himself as being at a 15, which means that they are hard and tiring, but continuing isn't terribly difficult.
Throughout the evaluation process, it was also found that Adam has active range of motion within functional limits and has good coordination skills.
Some of Adam's strengths include that he lives with his wife and son, he is reported to be cooperative, he has good coordination skills, his active range of motion is within functional limits, Adam is independent in bed mobility, and he ambulates without devices for short distances. Some of Adam's weaknesses include that he has decreased endurance, he has 5-minute sitting tolerance. For his transfers, he has contact guard assist for bed to chair, contact guard assist for sit to stand, and min assist for supine to sit. And Adam is dependent in all ADLs and all IADLs.
Here is a diagram depicting the various aspects of Adam's life that have been affected by his condition.
Adam's main problem areas that will be addressed during therapy include activities of daily living, such as grooming, bathing, and dressing, and functional mobility and work.
Adam's first long-term occupational therapy goal will be for him to require minimum assistance for all of his ADLs. Some of the objectives or short-term goals that will help us reach his long-term goal are: by day 3, Adam will properly demonstrate one breathing technique to utilize during an upper body dressing task. By week 1, Adam will complete grooming activity such as shaving at edge of bed with moderate assistance. And by day 10, Adam will complete lower body dressing with minimum assistance and no more than one break. Some of the treatment activities that will help us reach these goals are daily ADL retraining with fading physical assistance and breaks, practicing energy conservation and breathing techniques to utilize during ADLs, as well as practicing supine to sit transfers. An additional long-term goal for Adam will be for him to be independent in functional mobility and transfers. His short-term goals will to be demonstrating sit-to-stand transfers independently during a lower body dressing activity within 1 week. By day 10, Adam will demonstrate bed-to-chair transfer independently in preparation for a seated Wii activity. And by week 2, Adam will demonstrate a supine-to-sit transfer independently in preparation for an edge-of-bed grooming activity. During treatment, we will gradually increase his sitting tolerance while participating in meaningful activities such as browsing golf or sailing catalogs, engaging in a Wii golf activity, and working on his computer. Additionally, we will implement energy conservation training. Adam's final long-term goal is to independently identify and demonstrate energy conservation techniques for successful completion of work occupations. The objectives that will work towards this goal are: by day 4, Adam will verbally identify 3 energy conservation strategies that he can implement into his daily schedule. By week 1, Adam will independently demonstrate 2 energy conservation strategies while performing a work-related task on his laptop. And by day 10, Adam will properly identify his level of exertion in relation to the Borg scale during 3 functional mobility tasks. Some treatment techniques that will help us reach this goal include energy conservation and time management, stress management training, working to increase his sitting tolerance, as well as making work environment adaptations. After a workstation analysis is completed, we can help Adam download break reminders on his smartphone and train him on proper seating positioning and posture.
The 2 primary frames of reference that are appropriate to guide Adam's treatment include the rehabilitative frame of reference and biomechanical frame of reference. The rehabilitative frame of reference focuses on utilizing compensatory strategies and adapting the environment in order to improve successful performance during valued daily activities. The intervention approach that will be applied for Adam is to adapt his environment and modify tasks specific to Adam's needs. The biomechanical frame of reference is used to improve endurance to enable functional skills.
There are a variety of precautions that need to be considered during Adam's treatment. It's important to restrict his activities to the 2 to 4 MET range during the first 2 to 4 weeks after his myocardial infarction to allow his heart muscle to heal. Adam will be provided with a handout of different activities and their corresponding MET levels. During exercise, we will be sure to note his heart rate, blood pressure, and EKG response, as well as symptoms that we may observe. Additionally, we will not perform any isometric exercises during treatment. We will also be aware of signs and symptoms of exercise intolerance. Some examples of these signs and symptoms include chest pain or pain referred to the teeth, jaw, ear, or arm, excessive fatigue, shortness of breath, lightheadedness or dizziness, nausea and vomiting, an unusual weight gain of 3 to 5 pounds in a 1 to 3 day period.
To recap, some intervention strategies that will be used with Adam include energy conservation training, stress management techniques and relaxation training, home and work modifications to facilitate energy conservation and safety, progressive activities and low resistive exercises to improve strength and endurance, and reinforcement of lifestyle changes such as healthy eating, smoking cessation, and stress management techniques.
In regards to energy conservation, some tips to keep in mind are that standing requires more energy than a seated activity, and extremes of temperature, high humidity, and pollution make the heart work harder. Some specific energy conservation techniques that will be used with Adam include time management, planning ahead by assuring all items needed for a specific activity are close to Adam, minimizing the need to bend and reach, when possible, sitting for activities instead of standing, keeping good posture, making home and work environmental modifications. We will also train Adam on specific breathing techniques, such as pursed lip breathing, diaphragmatic breathing, and exhaling with exertion.
While Adam is in inpatient cardiac rehabilitation, he will be receiving occupational therapy and physical therapy in his room and also the OT gym in the mornings. His occupational therapy sessions will be 30 to 40 minutes long, 5 days a week, for 2 weeks. Occupational therapy's main focus is to increase Adam's endurance, strength, and independence in his ADLs and IADLs, so that he is able to return to his valued life roles of a worker, husband, and father. I am happy to report that Adam has met his occupational therapy goals.
Yay, Adam!
Adam is going to be discharged to his home with referrals to a cardiac rehabilitation program and stress management classes.